The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, this month with Dr. Shaun Mendenhall, hand surgeon at Primary Children's, the University of Utah. Welcome back, Shaun.
Thanks for having me back. Really enjoyed the first episode.
What this means is I get to ask really smart people things that I wonder about all the time. And so it's all about me and my needs, basically. So thanks for coming back.
Thanks for having me.
So you said you grew up in Utah originally. Which part of the state?
Yeah, I grew up here in the Salt Lake Valley. So I went to Hunter High School.
Hunter High, that's a good one.
Yeah, terrific. Yeah, it was great. I enjoyed it, and then came up to the university after for 7 years total. Or no, excuse me, I did 5 years of undergrad and then 4 years, so 9 years total at the University of Utah before going away for my surgical training.
Yeah. And you said you were at Southern Illinois for your plastic surgery, then at Philadelphia, at Penn and CHOP. You said you were back here for 3 years and then went back to Philadelphia?
Yes. So I was here for my first 3 years of practice, and again, doing both adult hand surgery and pediatric hand surgery. And then this opportunity came up to go back to where I trained to do 100% pediatric hand surgery. And so we had to take that opportunity. I thought it was a career opportunity, once in a career type thing. And so we went back there and absolutely loved it. And it's just such an incredible place to live and work. But eventually we decided we wanted to get back here and be close to family and connections here. And at that same time, they just opened the new Lehigh Primary Children's Hospital. And so the university invited me to come back and focus about 80% or so of my practice on pediatric hand surgery between the two children's hospitals.
That's terrific.
So that was great.
One of the things I'm hoping to highlight this week is that there are a lot of things that you do in hand surgery that maybe I hadn't anticipated. I think of hand surgery as being primarily a structural sort of thing, but it's a structural and functional practice if I'm reading what you do correctly.
Yeah, I think that's a very accurate way to think about it. You know, the hand, and if you just think about the hand and the whole upper extremity, it is such an amazing combination of different organ systems, right? We have the skeletal system, we have the nervous system with all the peripheral nerves, we have the muscles and the tendons, and then we also have the vascular system and the integumentary system. So it's very complex amalgamation of all of these organ systems, and then it comes together to function in just such an incredible way to let us live our lives in the way that we do. And if you think about all the things you do with your hands on a day-to-day basis, it's really most of our lives depend on them.
So much of being human we approach with our hands, and we don't think about it. We take them for granted. We misuse them all the time, and we depend on them. Before we go into the details, would you like to mention your disclosures?
Yes, I'm a disclosure for a company called Polynovo that makes an artificial skin or a skin substitute. And I just do a lot of teaching for them, and I've done some research with them. So that is my only disclosure.
Terrific. Okay, so two things. One is, and you sort of embody both of these, there is an advantage of some of these more problematic things being treated by someone who has experience with the various parts of the hand, because it's not, as I mentioned before, it's not just a bony thing, it's all of those other things. And you've been trained, with vascular surgery and neurosurgery of the hand, and all of these things that go into making our hands functional. And in addition to that, there are some advantages as well in having somebody approach this developmentally, that you're treating children primarily. So let's talk about a few issues that come up and what a hand surgeon brings to these. Let's talk about open fractures first. In what context do we usually see open fractures? What are the potential complications, and what's your approach to management of those?
Yeah, well, you bring up some really good points just in your introduction there that because the hand encompasses so many different types of tissue that you really have to become an expert in all these subspecialties of surgery. And so for open fractures, of course, that relies a little bit on sort of the orthopedic side of our training. And, these are often high energy injuries. So maybe a car accident. Here in this region, we see a lot of devastating hand injuries from the side-by-side utility terrain vehicles.
Oh,
So these are typically, they are some of the most horrific injuries we actually see. So a lot of times, this is a combination of speed on these utility terrain vehicles, and they go to turn and then the vehicle rolls. And what they do is they put their arm out of the vehicle and it goes around the roll bar. And so almost all of these end up having open fractures. And so with open fractures, we have a lot of additional concerns that we don't necessarily have with closed fracture. So an open fracture is any time that this break in the bone is exposed to the external environment. And so that creates a huge portal for infection in the bone and in the soft tissues. But in order for a fracture to be open, it damages a lot of the soft tissues as well. And so sometimes these fractures end up damaging the surrounding soft tissue so much that we can't close the skin over the fracture, and we have to resort to other means of moving healthy tissue around to cover this. And so there's a lot that goes on with these, but typically, thankfully, here in this region, we have Primary Children's Hospital, which is the only level 1 pediatric trauma center in the whole region for about 5 states. And so a lot of these patients get all shipped to us here. And typically they require emergent surgery to go in and clean up all the contamination and reduce the bone and start the reconstructive process. So that typically requires a big team, very highly trained and skilled individuals, both from the nursing side, from the surgical side, and the therapy side to get these children through these injuries.
We think about protecting heads with helmets, but a devastating injury to the hand could be very life altering for a child.
Absolutely. Sometimes they are even life threatening. But there are many of these injuries, especially that we see from the side by sides, that are certainly limb threatening. In fact, a couple of years ago, we decided to do a study where we looked at all of these side-by-side injuries and we compared them to just standard ATV injuries, like four-wheeler injuries. And we found in the side-by-side group, there was a 30% amputation rate, where it was only about a 3% amputation rate in the regular ATV group. So yeah, very severe injuries. And again, not often life-threatening, but they are often limb-threatening.
Which is life-altering.
Absolutely.
So is the difference, and I don't want to go on a long tangent here, but I'm fascinated, is the difference with the side-by-side the frame, or why is that more of a risk to the limbs?
Yeah, so the reason why they're called side-by-sides is the riders now sit next to each other, side by side, right? So they have either 2 or 4 seats. And instead of sitting front and back, like on a 4-wheeler or the old 3-wheelers, now you're sitting in this little dune buggy type vehicle that you sit side by side. And they do have this roll cage, and they don't have any enclosure, no hard windows. And so you can freely get your limbs outside of the vehicle. And that's what makes them so dangerous. And sometimes you can get, there's some safety features you can get added on, like mesh windows, so you can't reach out of the vehicle. Or you can use these little wrist straps that actually strap you to the handlebars in front of you. But anyway, our goal of doing this research study is to try to team up actually with the manufacturers and try to make these safer, just because they really have had such an impact on our region as far as the increase in these severe injuries.
Sure. Let's talk about somebody who presents with multiple fractures. What's the usual setting for that, and what's the management there?
Yeah, so multiple fractures, again, that's going to be typically in the setting of some type of high velocity injury. So a car accident, motorcycle crash, could be a mountain bike crash, but this is where they would have either multiple fingers broken, or they could have fingers, wrist, and even forearm fractures all together. And again, almost every one of the side-by-side rollover injuries we see has multiple fractures. And the problem with multiple fractures are it creates increased instability when multiple elements of your skeletal system in a close area together are broken. So for example, if you break one metacarpal, as long as it's in pretty good alignment, it's typically going to be braced well by the surrounding metacarpals, and it's going to heal well with good splint or a cast. But if you break multiple metacarpals, now there's instability in the palm of the hand, and those much more often require operative fixation and repair. So that's why multiple fractures can be a problem, is the more broken bones you have, the higher likelihood those need to be repaired with surgery.
I guess I hadn't thought of that before, but physics of all this requires a certain amount of architectural stability. It's buddy taping writ large that you depend on the rest of the structure to hold it together.
Yes, yeah, absolutely.
Fascinating. You touched last week a little bit on intra-articular fractures. Tell me about the challenge there and what you bring to the table there.
Yeah, intra-articular fractures are more problematic than those that aren't in the joint. And the reason is, the joints are so critical, and alignment of the joints for just day-to-day normal motion. And so anytime there's a break into the joint, we have to look very, very closely as hand specialists at how much that joint is displaced, because even just a millimeter or more displacement into a joint can cause that to not be congruent. And that leads to early arthritis. And so a lot of these end up requiring operative intervention to make sure that the joint stays healthy and normal. And so these push us more toward the surgical realm anytime there's a break into a joint.
How about growth plate injuries?
So growth plate injuries are interesting. I remember just growing up and, before I even thought about medicine, hearing about, if you get a break into your growth plate, that'll significantly impact your growth, and they're very scary. And that is somewhat true on the long bones of the body. But it turns out growth plate fractures in the hand are more the rule than the exception, because there's so many little growth plates in the hand. And so most fractures of children that are skeletally immature are in some way or another into the growth plate. But very, very, very few of these actually cause growth problems long term. So they're not as scary in the hands as they are in, say, the long bones like the femur or the tibia. The one exception to that is sometimes you can get some bad growth plate fractures of the radius, the distal radius. And those often do require operative management, and I have seen problems with growth from those. But growth plate injuries of the fingers, usually not a major problem, and they typically heal well and don't affect growth too much.
Let's talk about a big one, and that's amputations and partial amputations. What's the usual setting, and how do you approach those?
Yeah, so this is a big range of injuries from kind of minor to very, very severe. And the more minor ones that we see are these, really young little children that get their fingertips slammed in a heavy door. And sometimes that can result in partial amputation of just a finger. If it's just a fingertip, that's typically not too big of a deal. And many times, if it's just a small area of the fingertip, we actually just clean that up really well. And if we have the little part, we'll sew it back on. And even without reattaching blood vessels, we just put that on as a little, what we call a cap graft. And we recently just did a study on this as well. About 70% of those end up taking quite well as just a little bit of a graft and heal well and go on to do just fine. As you get bigger and bigger pieces that are amputated, so going up the finger more, then typically on a child, we almost always try to do something called the replantation. And that's where we take these children to the operating room and we try to reattach the amputated part. And we do that by first connecting the bone, and then we have to connect the tendons and the nerves and the blood vessels to keep that part alive and to help it survive. And we are the only center, again, in this whole region of the country that does that. So here at Primary Children's Hospital, because that is a very, very specialized, as you can imagine, technically demanding operation to do. So, and they're often very long surgeries too. These can last anywhere from, 5 or 6 hours, even to longer, depending on, how damaged the part is and if there's any complications during the surgery. But typically anything that's a major amputation, whether it's a whole finger, a hand, or an arm, we do our best to reattach that part.
What are the sorts of things that affect functionality of that reattached part?
So one of the most important things after, for example, if our surgery is successful and we were able to reattach the part, now you have this severe scarring that takes place around all those structures that you repaired. And so after our surgery is done and things are healed, then there's a significant period of rehabilitation after. And we have dedicated therapists that only focus on hand rehabilitation. And so they're called certified hand therapists. And they are a huge part of what we do and a huge part of helping children and adults regain function after these severe injuries. And so typically, an amputation that's reattached would take months of therapy, and therapy anywhere from 2 to 4 or 5 days a week of working with the therapist on getting all these structures moving again and breaking down the scar tissue. And so again, they're a huge asset to what we do, is working together with these highly skilled therapists.
Looking at the various things that you have to do there. So you're relying on the bone to fuse, you're relying on nerve repair, on vascular repair, on connective tissue repair. I'm guessing that there's probably some difference between those tissues and how well they lend themselves to repair. Are there any of those that are most likely to work well and the ones that are most challenging?
Yeah, on an individual structure level, the hardest thing is just that the tendons become stuck in that circumferential scar. And so getting the motion back after one of these devastating injuries is a challenge, and sometimes requires repeat operations to go in and clean up some of the scar tissue. But I will tell you that children typically do far better than adults do in this arena, because kids just heal everything a little bit better than adults. The nerves grow back better than they do in adults. And I think the overall function ends up being better than it does for adults.
I do get the impression, too, as you said, that having a good therapist to guide them through all this is very helpful. But I also get the impression that kids are more likely to push themselves in therapy than an old guy like me.
Yeah, it's such an art of the therapist to engage the kids, to be honest. So
Yeah.
they have to involve play in different ways and doing things that the kids really like to do. So that's one of the really special things about pediatric occupational and physical therapists, is they have to utilize a lot of means where our adult therapists don't, to entertain and keep them very engaged.
Right. You can't really browbeat a kid into doing something. You kind of have to charm and play them through it.
Yeah, and again, the nice thing is kids just don't have the same problems as adults as far as stiffness goes. As they scar far less than adults do for whatever reason. And anyway, to be youthful is very beneficial in the healing setting.
I'll keep that in mind. Let's talk about crush injuries for a minute. What's the usual setting for crush injuries? What challenges do they present to someone like you?
Yeah, crush injuries, again, a little bit dependent on the region of the country and what some of the common activities are. But we see, again, the most common crush injury is a heavy door getting slammed on a finger or hand. But we see heavy weights dropped on fingers a lot. Again, and any other sort of, recreational activities. We mentioned a lot about the side-by-side UTVs here in this region. But sports can do this. Sometimes you just simply get your hand stepped on in soccer or whatever it might be. But those are the usual settings. And the hard part about a crush injury is, again, these are composite injuries, right? They injure the skin, the other connective soft tissues, the bone, the tendons, the blood vessels. And depending on the severity, they can be some of the most challenging injuries to try to repair.
One other category that I'm guessing is also challenging in similar fashion, that's burn injuries. Burns and thermal injuries probably present a particular set of challenges.
Yeah, they really do. And again, the hands are a very vulnerable part of the body, right? Since they are the terminal device that we all use to interact with our environment. And so it's very common to get burns of the hands and the fingers, and burns can go from, very minor to just first degree burns, which are just kind of a reddening of the skin, to third or fourth degree burns, right? Third degree burn is all the way through the skin and into the fat, and fourth degree would be where it burns even into bone and joints. And So depending on the severity of the burn, they're going to have different treatments. But at minimum, a lot of times, second degree and greater burns require replacement of the skin. And so we have to get rid of all the burned skin, and we have to replace that skin with skin from elsewhere on the body as what's called a skin graft. And a lot of times on the palmar surface, those burns that are deeper, we do what's called a full thickness skin graft, where we actually just excise an elliptical piece of skin from elsewhere on the body. We close that up with stitches in a straight line, and then we bring that skin to the hand and we sew it onto the skin as a full thickness piece. And those typically heal quite well and have less secondary contracture problems. Then the alternative is the split thickness skin graft. And that's where we just take a shave of the outer layer of the skin from like the upper thigh, for example, and then we put that over the burned area. And we do those split thickness skin grafts anytime we need very large areas of skin, or they're typically okay on the back of the hand. But the downside with these burn injuries, especially those requiring skin grafting, is sometimes that scar shortens with time and causes contractures of the fingers. And if those are limiting motion and therefore limiting function, then many times we have to do revision surgeries down the road on those as well. And it's really nice here at the University of Utah in Primary Children's. We have a good multidisciplinary clinic where we have a burn team that typically handles any of the larger burns, especially those requiring admission to the hospital. And then we work together a lot on these really complicated areas, such as the hand or the face, for example.
And I'm guessing that your practice of intricate branch of surgery on children, that you rely also on a lot of other specialists. Imaging is different for these sorts of things. You mentioned the therapists and the nursing care, all of that. It's a great advantage to be able to build a program, isn't it?
It really is. Yeah. When you're dealing with children, there's a lot of other factors that we have to think about. And having these dedicated facilities just to children, where, again, the whole goal, right, of the primary children's hospitals are to make these children feel welcome and comfortable and like they're in an environment where everybody is there focusing on the child and helping them get through whatever they're going through. It's really a delight to work at a place like that, where you have everybody with the main goal of helping children get better.
Terrific. Any other things we ought to mention about complicated injuries today?
No, I don't think so. I think we talked a lot about them. I would just say, we certainly need to encourage all of our patients to buckle up and keep their extremities in the vehicle for any of these, recreational vehicles that are so commonly used in our region here.
Right. That's great advice. Well, Shaun, thank you for your time today. Hope you're up to coming back next week and we'll talk a little bit more. For those of you who have questions, please send your questions to questions@vcurb.com and we'll address those in a couple of weeks. Thanks again, Shaun.
Thanks so much, Paul, for having me.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.